So based on previous presenters and what we know, encouraging early and regular mobilization with Mrs. Tabulum is very important for overall health. Brenda, our physiotherapist, will provide us with further information about assessment and mobilization of the post-op hip fracture.
Hi, I don't like speaking into these things. Can everybody hear me? Okay. Usually I'm on the other side of the podium. I've come to quite a few of the lectures and I've learned a lot. So being on this side is a little freaky since I recognize almost everybody out there. But I am very honored and I do feel a privilege to be speaking today. So thank you very much. One other thing I wanted to say is I've been at Dartmouth General for 20 years now, which blows my mind. It's gone by very quickly, like the blink of an eye. When I first started in 1998, there was one other physio working in acute care inpatients, and that's Elaine Wellen. She's back there, and she's going to hate me for mentioning her name. But when I came, she was literally the only acute care physio for the whole hospital. So in those 20 years, you know, things have changed a lot. Staffing-wise, I don't think we're catching up to where we need to be, but things are certainly going in the right direction. So, and I'd like to thank Elaine for helping me with this presentation. And she's always there when I have a question, or she, you know, I was gone for 1.5 years, so she helped fill me in on what was new and what was going on in the hospital. So, and at the end, if there's any questions, maybe she can help me answer them. Now she's really gonna hate me. I do feel, I've been there so long, I do feel like part of the furniture, the old furniture, not the new furniture, not the nice ortho chairs that go back, the old furniture. So it's a down button, is it? Yay. Okay, this I think is the same slide that Dr. Legay used, and he pretty much could have done my presentation for me. Because what I've noticed with all of the presentations is that there's a big overlap in the dialogue that we're using and the message that we're trying to get across. So I think that says a lot to we're doing the right thing because we're all trying to be on the same page and follow the same plan. I took about 95% of my information from this tool and found it very helpful, I was like, oh yeah, everything is in here. But the other 5% I kind of made up myself based on my own experiences. Professionally, I've seen many hip fractures in the times that I've been working at Dartmouth General. Personally, I've also been on that side because my mother fell a few years ago and fractured her hip, and Dr. Venugopal fixed it with a dynamic hip screw. And she was partial weight bearing, then weight bearing as tolerated, I think. So, and a lot of you may remember her being in there because I was, I think, sleeping on a cot in her room, which is really weird sleeping in the place that you work. But so I've been on both sides, so I do get it. Okay. This is what some people think we do as physios. And you'll go somewhere to a function or whatever, and someone will introduce you as, this is Brenda, she's a, you know, she's a physiotherapist, and then all of a sudden the person will go, oh, my shoulder, oh, my back. That will happen forever, but that's not really what we do. We're not going to assess you at a Christmas party. What we really do is this, and that could be Alice. It looks like the other picture of her, walking with a walker, transfer belt for safety, wheelchair behind in case she gets tired and needs to sit down, and we all look so happy. So that's real life. No. So poor Alice, her hip fracture journey continues along. Dr. Legay certainly went over this really well, and I'll just quickly say the first 3 fixations, I believe, are the internal fixations. And this goes to talk about precautions and contraindications. Those surgeries, as Dr. Legay mentioned, we don't want them to twist or pivot on a planted foot to damage the hardware that's in there. And falling, we don't want them to fall. Falling's always a contraindication. But what happens in hospital is staff often give those patients the same precautions and contraindications as a total hip replacement. Now, in a way, that's not a bad thing, because that's not going to hurt the person who has the internal fixation. It's just going to give them more work to do, more things to remember, and if they have a dementia or a delirium, it's going to be confusing for them. So really all they need to do is don't twist, pivot, and don't fall. Whereas the bipolar hip replacements and the total hip replacements have the precautions of don't bend beyond 90 degrees at your hip, no twisting, and no crossing your legs or your ankles, which is very hard to do if you've ever tried that, because I do it all the time. But those things can dislocate the hip, and I believe it's easier to dislocate a total hip than a bipolar hip, but we still have to give the precautions to those people. Now, an internally fixed fracture, if it fails for whatever reason, and we need to move on to a total hip replacement, then again, the precautions would change. And the people coming in with a total hip replacements from home are, like Dr. Legay mentioned, you know, they're pretty happy because they came in because they had osteoarthritis or rheumatoid arthritis or avascular necrosis, and basically that problem is fixed. But somebody coming in with a hip fracture is now dealing with something they weren't planning on that has a lot of precautions and contraindications, and so they might not be quite so happy. And they weren't having the pain in their hip like the arthritic patient was. So all of a sudden they have a pain they have to now deal with. So this is, Alice came in, she was assessed and had surgery, and this is the inpatient referral that the nurse has filled out on the floor. I'm just gonna grab my water. It's a fall hazard, by the way. Anyway. So if you can fill out as much information as possible, that helps us prioritize our case, although a hip fracture is pretty high on the priority list. But if we get 4 of them at once, then it might help us prioritize that way. So we need the name, we need the surgery, preferably have the date of the surgery. It needs to come from orders within the chart from the orthopedic surgeon. Please sign it because it's a legal document, and at the bottom we'll just write where we have put our assessment, because there's a couple different places that we can put it. So that's faxed down to our department, and then we bring it up with us upstairs, and we write on the original that's in the consult section usually. Now these are the orders that are in the chart. So when we go up, we look through the chart, we find the important information that we need to know, but we definitely need to see this. We need to see that the surgeon wants us to see them. Their weight-bearing status is hopefully weight-bearing as tolerated, although there are cases where it can't be. But we find elderly hip fracture patients do not do well with non-weight-bearing or toe-touch weight-bearing. They just don't have the strength and sometimes the cognition to understand what that means and how to do it. And just the physiotherapy that we've been consulted. So sometimes we go in to see the patient and we can't see them right away. We can't do our thing right away. So there are so many reasons that it might be postponed either by a few hours or a day or even a day or two, which I know we don't want to happen because it's not ideal, it's not best practice. But if they're medically unstable, if they have extremely poor pain control, we try to coordinate it with physiotherapy. So they get their medication a half an hour or so before we come in, but that's not always possible. Something else may come up, we may get pulled away. If there's no orders in the chart and no weight-bearing status, we can't go in to see them. If the patient is competent and they're refusing, absolutely, adamantly saying no, then we cannot drag them out of bed. If they have some problems with their cognition or they can't communicate verbally, we also take this as consent, is if we say, show us how you get out of bed, or we're gonna go for a walk, and they just kind of automatically start to get out of bed. We'll take that as the consent. They understand what we want them to do, and they're starting to do it. And we always plan to discuss with nursing, the physician, the surgeon, to clarify what we can and cannot do with these people and when. So communication is a big part of the plan for the hip fracture patient. So the way that we do that, bed rounds every day. We can't always make it every day, but we try. There's a whiteboard in the patient's room, which we all should be filling out, and we try. Just having little side conversations sometimes too is enough, and also reading the chart. There should always be some updated information on how they're doing. So, the goals for all of our hip fracture patients, including Alice. So there's a lot going on in our minds. We're trying to critically think, how are we going to get this patient home? Are they going to reach these goals? Are they realistic goals? So what we're doing is we're basing it on their pre-fracture capacity. Daily physiotherapy, preferably twice a day and 7 days a week. And we can do that now, for the most part, because we've increased our staffing numbers. We want them to be independent when safe transfers, independent ambulation with an appropriate gait aid. I don't think Alice used a gait aid before she came in, but her being independent with a walker would be passing the test. Gait quality, their endurance, stairs if they have them. We like them to be up in the chair for all meals when possible, but again, if they have a pressure ulcer, especially on the coccyx or buttock area, you don't want them sitting too long, and probably with a Roho cushion, so OT should be consulted in that case. And yeah, coordinating the pain medication and mobilizing to the bathroom when able, or a bedside commode. So we have a love-hate, or I have a love-hate relationship with bedside commodes. It's a much better option than a catheter and a bedpan, but it is not as good as walking to the bathroom. So it's kind of an in-between sort of thing, because it sounds like Alice was rushing to the bathroom, I think at night, because she was having loose stools. And that happens quite a bit with people. They rush. And if it's dark and they're just waking up, all those things can lead to poor balance and maybe some orthostatic hypotension if you're just jumping out of bed and trying to run to the bathroom. So having a bedside commode is great for nighttime, especially, so people don't have to rush. It's right there. The only problem is who's going to empty it the next day, so you have to think of that. Some people already have them at home for nighttime use, especially if their bathroom's a little far away. And you could have it there just in case and practice walking them to the bathroom and just have that there in case you need it. But it does save urinary tract infections, you know, from having the catheter, and bed sores from the bedpan. So I like having it there for those reasons. And if it's there, then it can also be used as a form of exercise. So each time they get up, they're transferring, they're learning how to step, how to move with the walker. So it can, you know, be a second goal to have that there. The other thing is, if you're leaving them on the commode or walking them to the bathroom, you have to make sure that they are absolutely cognitively able to ring the call bell for help or call out for help when they're done, because if they have some delirium or dementia and don't know to do that or forget to do that, and you have to step out of the room for a minute, that puts them at more risk for a fall. So intervention with Alice. These are the things that we keep in mind. We have to do exercises, bed mobility, transfers, ambulation stairs, and equipment. So if you see us running around like chickens with our heads cut off, that's why. So the post-op exercises. I exercised once, but found out I was allergic to it. My skin flushed, my heart raced, I got sweaty and short of breath. It's very dangerous. And some patients actually are it's very hard to convince them to do the exercises, while others are more than happy to. This is the sheet that we hand out to all the patients, and it's basically range of motion and strengthening. We kind of ease them into it. We want them to do it 3 times a day, 5 to 10 repetitions of each. This is the other, that's the other side of the sheet. The bottom 2 are more for knees, but they can do them if they so wish. So we'll give them the sheet in the hospital, and hopefully their family can help them with that, because we want to keep the family involved as much as possible. So the other thing we're going to do is ambulate, transfer and ambulate. So we show her how to get out of bed. These are home grab bars that this person has up here, and a leg lifter. That's a little cheating device that we can use initially until her leg gets stronger. The person on the side over there with the walker, I noticed as I was going through a few things I don't like about this, is he has a 4-point walker, whereas I would rather he have a front-wheeled walker with rear skis. With a 4-point walker, yes, you have a little bit more stability, but the problem is you exert more energy because you have to stop, lift the walker, put it ahead, put it down, step in, and you have to do that with each step. So it takes more energy, and you don't have a normal gait when you're walking within it because you keep stopping. And I think his slippers don't have a back on them. And we don't like that, because people can step out of their slippers or get their other foot on the slipper and kind of trip them up. Same with Crocs. We do not like Crocs. They do the same thing. And I can't really tell because I don't have my glasses on. I don't think he has a Johnny shirt on behind him. So he might be getting a cool breeze in the back and giving a show to everybody who's out there. So those are the few things I would change with that. These are stairs. They're not the exact ones we have in our gym, but they're very, very similar. I call them the stairs to nowhere. So we need to practice stairs if the patient has stairs at home. If they have no stairs and don't want to do stairs, then sometimes we leave it off, because sometimes they haven't done stairs in years and it's not really a goal they need to achieve. But sometimes if they have family members who have stairs and they're going there for Christmas, then we may need to do that. So we tried to practice the way they were doing the stairs at home before they came in. Sometimes people hold on to the railing with 2 hands, sometimes they hold on to both railings, or sometimes they use a cane. The challenges that we face, If they come in with limited activity abilities, their cognitive status, can they retain the information? Are they learning anything when we see them? Does it stay with them till the next day, or do we have to start all over again like Groundhog Day, which does happen a lot? Poor pain control, as I mentioned, medically unstable if they're refusing physiotherapy. And I mean, it's not like we offer and walk away. We really try to convince them. We, explain all of the complications. We, say the doctor wants you to do this, your family needs you to do this, you want to go home, and we try everything, but they still may say no, and we cannot pull them out of bed. Hopefully their weight-bearing status is weight-bearing as tolerated. Constipation, pain, I know that's been mentioned a few times. I find that is one of the biggest blockers that we have, literally, because people come in and they're in pain, so they take their pain medication, they're narcotic, and then they start to get constipated, and then they start to get distended in their abdomen, and then we come in and they're like, oh no, I can't, I'm in too much pain. And then we try to explain walking will actually help the constipation because it'll get things moving and you'll feel better, but they don't believe us. So they stay in bed and take more medication for the constipation pain and then get more constipated. So that has actually kept people in bed for a day or two with us trying to explain, you need to get up. So they may need some medication to get that started, that process started anyway. And fear of falling, I find that to be probably one of the biggest limits in what we try to do with patients. When you look at the pictures, I mean, these ladies have walkers, but they both fell in the bathroom. It looks scary. It's a catastrophic event that's happened in their life. And with Alice, this is her third fall that we know of. So it stays with you. And I'm not sure about the lady with the dark hair. She looks unconscious. I don't know. I don't know if Alice lost consciousness either. But you have no phone. You have no way of contacting anybody. You don't have any food or water. You probably need to use the washroom. And you're in a lot of pain, so you can't stand up. You probably can't crawl. So you're stuck there until somebody comes, and you may not know when that's going to be. And unfortunately, we can't prevent all falls. I know a lot of the titles say fall prevention. We can minimize the risk, but we can't take away all falls. And I'm just going to quickly tell you, I broke my ankle. I had a tib fib fracture in many places a year and a half ago. And Dr. Hurley fixed it, and thank you to his whole team for what you did, because it's really amazing what I can do with my leg now. And a lot of the nursing staff probably saw me, and maybe I can talk to you later after, because I have blank spots in my memory of what I said to people from the morphine I was on. So I'm kind of missing little pieces of what happened. So if you can fill me in, that'd be great. So, because I'm a little embarrassed every time I see somebody. But I was not afraid of falling until last Friday. So a year and a half later, I became afraid of falling. That was when we had the snowfall, and it was a fair amount. I got out of my car to come to work and realized I couldn't see what was underneath the snow. The snow was flat, but I couldn't see the gravel, the bumpy pavement, the little potholes in the parking lot, the stairs that I take to go down. And I started walking, and I realized I was terrified. And I could feel every muscle in my body tense up. My legs, my butt, my back, my arm, like everything. And I was taking these small little steps because I wanted to make sure I felt every nuance in the ground so that I would be prepared to react to it, because I knew that my right leg wasn't going to react as fast as my left. And all I could picture was me falling and twisting my leg the way that it was with my foot facing me. So that image is burned into my brain, and I understand why, because I didn't have the visual cues of where I needed to be. So, and that took 1.5 years to happen. So certainly Alice could feel that way, because she's had 2 previous falls. Sorry, that's a cat. But she tripped over her dog and broke a wrist. She fell on ice and broke a wrist. I mean, we can't always prevent those. Ice is, you know, sometimes you can tell there's ice there, sometimes you can't. So those things happen. So she's had some traumatic falls. But we can minimize the risk at home and at work. We would never see this at work. And probably not at home. Nobody would do that. Although I have had some patients who've been like 95 and say, oh yeah, I was standing on a chair trying to fix my curtains, and yeah, they come in with a hip fracture. And they're totally surprised that it happened. We kind of already went through this about having a safe environment and engaging the family. These ones I can kind of go through. Having the call bell and phone within reach, a bed alarm or chair alarm if they're getting up and they need some help. Proper footwear, I hated those slippers. And communication between the patient, the therapist, family, staff, so like bed rounds, charting, meetings, whiteboard information, that all helps. A lot of falls happen in the bathroom, so to minimize that risk, do not do this. I have no idea why they are doing this. I just typed in on the computer, you know, falls, and this is what I got. So don't do that. But you know, at night you may want the bedside commode, proper lighting, make sure they're not rushing if you can, and proper footwear. And this says tips to prevent falls. Again, I don't think we can prevent them, but they're good tips, like removing scatter rugs. That's kind of an OT thing. Watch out for pets. The writing on here is really small, I can't see it. Yeah, if clothes are too long, make sure you hem them and clear up any junk or stuff in the way so you have a clear path to walk. And if you're on, if your blood pressure is a little low, and even if you're on medication, sometimes that happens, but it's worse in the hospital. So you get them up and they fall right back down. So we have to be aware of that. And this just kind of is me. It takes real skill to choke on air, fall upstairs, and trip over completely nothing. I have that skill. And so equipment for home. We need to start planning when Alice is getting, you know, more independent with all her mobility. What is she going to need for home? Does she already have everything just in case, or does she need everything? You can go through the Red Cross Equipment Loan Program. They will lend you equipment for 3 months. You don't really have to pay them, but they appreciate a donation when you bring it back. And we have the form, I'll show it to you in a minute, and it should be on all the floors. They can also go to a local vendor, it's totally their choice, and buy or rent the equipment, but they may need a prescription from a doctor for insurance purposes. And like I said, they may already have the equipment, so they can borrow from a friend or family. And sometimes we like them to bring in their ambulatory aids just so we can assess them, especially if they're old, and to make sure they're the right height for them. So to work on transfers at home, the first one on the right is a bed rail. I actually got that for my daughter when she had surgery, and it was wonderful. It worked really great. And this is a super pole in the middle, mounted to the floor, because often it's a lot easier to pull yourself up than it is to push yourself up from the bed. And the chair down there is pretty expensive, but it does help people stand up. And grab bars, grab bars, grab bars everywhere. So first one up top is for the bathtub, and it looks like the second one's in the shower, and the other one is kind of multi-purpose. And this is all what you use instead of the towel rack. You use the towel rack, and one of these days it's coming down with you. So have the proper rails installed. And ambulatory aids, this is the walker that I like with the front wheels on it. There are actually skis on the back, and it folds so you can put it in the car. Cane for stairs, they might need that. They probably won't be leaving the hospital walking with a cane, not enough balance, but they might need it for stairs. And crutches. Personally, I'm not a crutch fan unless the patient is really young and is comfortable with them. I had the crutches, and I did not feel safe with them. So we'll try it with people if they want to, but if they're unsafe, we'll stick with the walker. Shower tub safety, there are different things like a bathtub transfer bench, a bath seat, handheld shower. These things all let you sit down in the shower so you have balance, you're not going to fall, and you're conserving your energy. Some of these things the Red Cross doesn't have, and again, the commode that I love to hate, and you can get arms for beside the toilet to push yourself up, and if you are a tall person and find the toilet too low, you can get the raised toilet seats. And this is the form for the Red Cross. Any health professional can fill it in, put as much information again as you can, and there's a number there to fax it to. And then you give it to the patient or their family, tell them they have to call and make sure that the Red Cross has the equipment, because lately they've been running low on some of their stock. And then the family go pick it up. It's in Dartmouth on Troop Avenue. We do not pick it up or bring it back, so they're responsible for it at that point. So discharge planning, so Alice is doing really well. She's up independently. She's with a walker. She's walking to the bathroom. So she's basically at her pre-surgery level of mobility, except she has to use a walker. But that's okay. That's expected. And she can do the stairs safely. She's basically plateaued at that level because that's her baseline. But if we had a patient who was refusing physio, aggressive or combative, or unable to learn the skills for transfers and ambulation, then that becomes a bit of a problem because we can't say they can go home safely. So we need to think of where are they going. Alice, from what we've done, sounds like she can go back home, especially if there's a friend with her that can help her, or if she can go stay with family. She could have formal supports at home. She could have some informal supports as well. If she's not quite where we think she could be, we could ask for an assessment for restorative care in Halifax, just until she gains a little more independence. And then another option is long-term care. So we have to keep all these things in mind when we're looking at where is she going. And we don't decide these things. This is a team, family, patient meeting that we have to have if necessary. And yeah, the more you move, the better it is for your bones and your muscle mass, and it does reduce your fall risk. But of course, you don't want to press your luck and do something like that. And I'd like to dedicate this project to my cat Sally, who obviously thought I was lonely. She sat on my keyboard the entire time, making this take a very long time to do, but it was nice of her to join me anyway. And that's it.